To continue the program tonight, I'm going to turn things over to the HHS Chief Technology Officer, Brian Sivak, who leads our Idea Lab work. And he is going to moderate the panel, and then he's going to turn things over for open questions. So, Brian, over to you.
Thank you very much, Damon. And thanks to all of you guys for coming today. Thanks to the panelists for both keeping your talks in the allotted time, which I will say is amazing, but also very interesting content. Before we get started, I just have a really quick question. I'm curious who's here. So how many people here are from government? Quick show of hands. OK. How many entrepreneurs? You can be both. How many academics? None, 1, 2, 3. Data scientists? Few. OK. So it's important to me to kind of understand the crowd here, because one of the things that we've focused on for the last 5 years at HHS when it comes to open data is really trying to understand who the people are out there in the world that want to use our data, that are leveraging it, that need to have access to it, or that want to have access to it, so that we can make it available in a better way. One of the reasons why I think this particular panel and this audience is really interesting is because it's very rare, unfortunately, that we actually get the people who know about the data in public talking to people who want to actually use the data. So to me, this is a great opportunity for everybody in this room to actually ask some questions, make them hard questions. If they can't answer them, I'll try to answer them, or we'll just pass and figure out what happens next. But I do think this is a great opportunity to work on stuff like that. So I will ask a few questions to kind of get the conversation started, but I would actually much rather, instead of me asking some questions, hear from you guys what is interesting to you, what kind of things you've been wondering about, and direct them to the folks sitting up here. I think it'll help all of us in terms of what we try to do and how we try to do things. So start thinking about some questions. We'll maybe do some moderated stuff for about 20 minutes and then turn it over to you guys, and we'll kick it off that way. So cool with you guys? Everybody good? All right. So one question that I was actually wondering about for really the startup folks here. Were you aware of all of these data resources that were being discussed on stage today before they were discussed on stage today? I mean, you guys are obviously part of this universe, and you've been thinking about this for a while. Did you know this, or did you learn about stuff today for the first time?
Yeah, I mean, I'll be honest. There were definitely some data sets I did not know about at all. And the recreation data sets, I think, actually could be pretty useful, because we actually posed the question related to, are you looking for areas to walk and actually find exercise and fitness programs? And that would be a really powerful intervention based on that question we pose. So I think that generally, for us, it's at times a bandwidth issue. We have so many ideas of what we want to do and help and contribute back with some of our data sets. But we're trying to look at, we're a small team, and trying to figure out which data sets are most valuable in the early stage is kind of part of the struggle. So some of the general data sets we do use related to health centers, veteran services, mental health, behavioral health services, home health agencies, those are the ones we end up using right now. Mm-hmm. But I think there's a tremendous amount of value to be gained on I've seen data sets on wait times and things like that, which I think would be pretty powerful in really improving how individuals use our services in the context of a care center.
Got it. And Shelley, how about you?
Thank you. Yeah, actually, the Park Service was also interesting for us. I'm thinking already of a client that we're talking to that will definitely benefit from that. Yeah, definitely there's very specific things people mentioned today that I was not aware of before. But we're thankful for what you have out there. And I think one of the things that we've been talking about, looking at more specifically, that I was just talking with Damon about, is the quality. What are the quality indicators? How can people that are seeking services know if an agency is actually doing what they say they're doing, but doing it well? And so when people started talking about performance measures, that's something I'm definitely going to go back and look at.
Great. For the government folks here, so sort of along those same lines, when you look at the data sets that you have available, and you think, we have this great piece of information, why isn't anybody using it, or is anybody using it even? What are some of those things, and what data sets do you guys have that you think could be better used? And we can just start and go down the line if you guys want. I'll call on you first because you're right next to me.
I tried to go to the other end. It just didn't work.
We'll start the other way next time.
A lot of our data sets that we end up gathering, it's more for our internal use for managing the lands and how we can better manage the resources that we have there. But I will kind of mention there is a DOI is hosting a developer summit on April 11th and 12th, where they actually are trying to work on different tracks and developing applications developed around citizen science, starting from people's backyards, working all the way out to being in larger areas, as well as around some civic mindedness apps. Well, I know it's maybe not quite targeted toward this group. There are a lot of the data sets there. We are looking to see what are some other ways that we can help to get people to connect with their public lands.
Before you go, actually, a couple of quick things. So you mentioned that data sets, most of your data sets are meant for internal use. Or some of your data sets are meant for internal use. I wonder if some of those data sets could potentially be useful to external people as well.
And I'll go with you, yeah, a lot of them are. That's why I was trying to mention, we do have them. They are publicly available, such as the vegetation species, where for us, we're managing how is the vegetation changing, what is going on there, as well as the park species, what are the animals are there. We're having to manage that from a land management to know what are our resources that we even have.
Interesting. Okay, so I think you guys might or might not be familiar. There was recently so every agency is part of this memo that was sent out by OMB has to maintain what's called an enterprise data inventory, an EDI. And that EDI is supposed to be made public. Recently, the Sunlight Foundation filed a FOIA request for every agency's enterprise data inventory, which theoretically will then allow the public to see a list of all of these data sets. So I'm wondering, it'll be interesting anyway to see if there are some data sets that people don't know about, that they find out about through this FOIA request, that then all of a sudden we wake up and say, oh, wow, that actually is an interesting data set that we hadn't considered. So it's just something that's been intriguing to me. I'm kind of curious if you guys thought the same way. Should we move down?
Sure. As I told you a little bit before, we have been looking at all our data sets just to see what's there. And the majority are annual reports to Congress. Congress gives us money, and we're required by law to tell them how we spent it. And my goal, and hopefully yours will be too, is to turn that into something interesting, for goodness sakes. So there's a lot of casework data that goes in there, how many cases were processed. There's also how many full-time employees were employed at each state. So from a business perspective, we're trying to make it so states can determine what kind of bang did they get for their buck. We're taking health and human service data and looking at it from a business perspective and trying to make, we don't make a profit, obviously, but our profit would be serving more people, having more resources to serve more people. So we're just trying to chop it up and do more with it.
Great.
At ACL, we have a range of different data, but a lot of our data is really, I think, applicable for correlational studies. And there have been some studies looking at nutrition program spending, because ACL does have a nutrition program for older adults, home-delivered meals and congregate meals. And there have been papers published on correlations between the level of expenditure of that program and the level of individuals in nursing and other institutional facilities that are low need. Because one of our goals is to have people that have low need or low risk to be in the community and not to be in institutional settings. And so that study was interesting, and we have a lot of other data, not just nutrition data, but data on transportation, data on homemaker and chore service, data on caregiver services. And I think that data is ripe for those types of correlational studies, looking at various things that are happening in the state and their expenditures in these different areas and how they're managing those expenditures. So there would need to be other data connected to our data, data on nursing home enrollment or other things like that. But I think our data really are ripe for that type of thing. And our data in that area are at the state level, and so that's why I mentioned state level data sets and correlations.
That's great. And Stephen, I know you said you don't have any data, but I think you probably have some.
We do have some. I was speaking mostly about the national level claims data, which I think is what people usually are asking me about and for. So in terms of what data we do have available, certainly states have some of their data sets and have been working with people to make some of those available. We have some of the workarounds we have are ARC has a database called HCUP, which you can look for by payer-specific data, and so that's how I get a lot of my intel about the program now. And CMS, the agency, has tons of data that we're putting up online. So Hospital Compare, for instance, on quality indicators, for instance, somebody mentioned, and that's all payers. So we're in there in terms of a lot of the data that the agency is making available. A lot of states have data. Other agencies have Medicaid-specific data. I think I'm just really hopeful for when we can think about how we make that national claims level data in a useful format. And I will say part of the challenge is, of course, about the privacy issues and not just HIPAA, but really being consistent with the spirit of HIPAA in terms of what do we actually do and how are we being responsible to our beneficiaries about this. We have a lot of issues still to work out there. And although that last thing just to mention is that there's a data set called the Chronic Conditions Warehouse, which is a data set that theoretically is technically only available to government entities, but often outside partners, particularly academics, have linked into that data. And starting last year, Medicaid data is now in that data set, and that's new. And so I think we're starting to put our data into places that it wasn't before. Hospital Compare, for instance, used to be Medicare, now it's all payer. So we're trying to get where we can get it into the existing portals, as well as trying to think about how do we make our own data finally available.
Yeah, and I would add also that CMS has really been doing some pretty interesting stuff on the data front over the last couple of years, culminating recently with the appointment or the creation of a brand new position at CMS, the Chief Data Officer, who Niall Brennan is currently filling the role. And really has been, that organization and Niall have really been doing a great job of pushing the envelope and making CMS data, everything from claims data to the compare data sets to a whole bunch of other stuff, much more available. And because I love flooding Niall's inbox with requests, you guys should definitely feel free to email him at niall.brennan@cms.hhs.gov. And somebody please tweet that I just gave out his email address because he will be so thrilled. Paul.
So what I put up on the slides, I think, are the big ones we have and that are publicly available. And I think a lot of them are used a lot. I know a lot of people go into the health center and look at the UDS and try to find what they can know about our health centers and the patients they serve. But in that vein, I think we know that our data covers a lot of topics to the point that we can't look at all of them. I think the surveys I put from the Maternal and Child Health Bureau are great examples of those surveys cover so many different topics about children's and children's health that we can't look at all of them. And there's definitely opportunities to go in and look and try to find a new lens to something and find new solutions or ideas in there. So.
Great. So let's go back to the startups for a second. And sort of along these lines, what gaps do you guys see in the data? What do you wake up in the morning and think, man, if we only had access to X, and maybe if X is sitting on this panel with you, that would be kind of cool because we could have that conversation.
So X for us has been mentioned. Medicaid claims data would be amazing to look at.
Excellent.
Because that's, as I kind of mentioned in my presentation, that's one of the main reasons we started Healthify was we want to prove that if you're smart about how you address social determinants, you see it's not only the morally responsible thing to do, but it's a fiscally responsible thing to do as well. And the only way we can do that is by really analyzing and comparing it to claims data. So I think that's one of the major gaps. Generally, I think information and data on what care coordination protocols work, and this is my bias from healthcare, at least in the communities we work at, we see incredible fragmentation in case management protocols, care coordination protocols, community health worker protocols, everything. Screening assessments, duplication of screening assessments, and I think information and data on what is the best way to do it would be hugely beneficial. And also information and data on how this information should be shared and interoperable with existing IT systems would really push the field forward as well. And I know IOM is doing some interesting work with how do you capture social and behavioral determinant information in EHR, so I'm really looking forward to how that resolves, but that's kind of what we're seeing.
So as a social worker, I would love to answer this question, but I think it would be best addressed by our CTO, Declan Fry, actually, if I could throw it out to him.
Sure. Where's Declan?
Sure.
Thank you.
Hope you were paying attention.
Hey, I was just taking some notes. The question is, what data
What are the
would
gaps?
we like to see?
Yeah, what do you, if you could make a wish list of data, what would that data be?
Yeah, one thing that I think is really important to us, it sounds like might already be out there, and that's information on outcomes of various programs. That would be really helpful to us and to our clients in assessing which programs are really useful and doing what we hope that they're doing. Another thing, just as a general point, we would like to see data being released in standard formats when available. Just makes it much easier for us to ingest that and process it.
Great. This might be a question more for Susan and Jennifer. One of the things that we spend a lot of time thinking about in my office is how we measure the effectiveness of our programs. And when it comes to the health data that we put out there, one of the things that we're constantly trying to figure out is how do we measure the effectiveness of these data sets that we're cataloging and making available to the world? And so given your backgrounds in sort of program analysis and data analysis and things like that, I'm curious, are you guys thinking about this and measuring and by the way, everybody should feel free to answer this, but are you thinking about measuring the effectiveness of putting these data sets out there in any way, looking at who's using it, whether that actually is having the impact that you wanted to have, all of that kind of stuff?
Well, it's interesting. When you think about who is looking at it, we do have Google Analytics set up on our site. But it's interesting because our site is sort of a pointer to the home location. So we're not necessarily getting a read on, did the person visit from us? Did they visit from data.gov? So it's still in process that way. Now, interestingly enough, the way we find out if our data sets are useful are through humans. So just this week, I had one of the guys from South Carolina come and talk to me, and he said, hey, you know that data that you gave us? What we did is we put that as an infographic on the proposal for Rule 25, and we sent it up to the legislature. And I'm like, that's great. So that's a positive. Another one of our guys who represents Puerto Rico Child Support Enforcement area, they took our data as well, and they took it up to the legislature in Puerto Rico. So I think it is being used, but not necessarily from a metrics sort of way. It's sort of word of mouth.
Anecdotal more than anything else.
More anecdotal. Yeah. But I guess we're sort of at the data evangelization point.
I like evangelization. That's a good word.
Oops. I feel like I should sing like a lounge singer now. Before I start singing, I'll pass it over to Susan, though.
I would say our answer is very similar to what Jennifer was saying, that we do have some Google Analytics, and particularly for our aged system, we know a little bit more in detail about which pages people are looking at, how long they're looking at them, and if they're downloading them. But since a lot of the data on aged is downloadable, we don't know then how often they're using those data once they download them, except that we see publications, we see conference presentations, people ask us questions, and a number of the advocacy organizations for individuals with disabilities and older individuals come to us and use our data, and when we see it in the public, then we know it's being used. But we don't really have a comprehensive, systematic way to understand that. But we are working, actually, to improve the aged system, and we're doing some surveys and interviews with people that do use it, particularly at the state level at this moment, to find out what would be better, how they could use it better, how we can organize the data better to make it more useful, make it the format really that they need to use it in, so that they have a question, that answer is right there. They don't have to put together 3 or 4 data points to answer their question. So we are trying to make it more useful, but we still don't have a systematic way for measuring that use.
Yeah, one of the things that, I mean, we've been thinking about this a lot because we face exactly the same challenges with healthdata.gov, actually one level up, because we actually don't know who eventually is using the data that's cataloged on the websites or that exists on the websites that we catalog. One of the things that we're working on doing, this is sort of probably information for everybody here, is really thinking about revamping healthdata.gov to really focus more on the community aspects of data. So right now it's a catalog. It's got some features and functionality for people to submit questions and interact and ask the community things. But we're thinking about ways to make that much more prominent and effective. We want to have healthdata.gov to be sort of that central hub, if you will, for people to actually ask all kinds of questions, to get answers, maybe not have to wait for a forum like this to actually interact with people inside the government. So we are always open for ideas on that, whether it's from inside of government or outside of government. And so I would really encourage you guys to let us know some of those thoughts, because I think it'll probably help with all of these things as well. Either of you guys have anything to add to that, by the way, around the metrics? Or Paul, you got anything? Adam, anything? Nothing?
Just, we're in the same boat. We track what comes down off our websites, what's downloaded, and I think a lot of our offices and bureaus find out about how it's used by, it shows up in our grant applications, or it shows up at the grant meetings with the publications of, look, we know this about our patients, and we've used this.
Sure.
And I think that's a lot of how we find out what we have to change.
And and I have to say, I'm on a lot of panels with Seiji, the CMO for HRSA, and I'm always so jealous. He always starts off his talk, whatever topic we're talking about, with a couple little data points about the issue that we're talking about for the day. I'm just like, hey, I want that. So, I'm always, I have huge data envy. So I'm going to spin the question slightly differently, which is that, I think you're talking about how do we measure the effectiveness of our data programs. Just to twist that around a little bit, I think we often talk about how we matching the data to the delivery reform and the payment reform that the state is trying to engage in, because we're always thinking about it from the state perspective. And I think what we often see is one of two problems. And I think we often see I call it, they've built a Ferrari to drive around the block, or they're trying to fly to Timbuktu in a Chevy Nova, right? And so how do we think about actually making sure the data system they've built matches what they want to do, or conversely, that we're not matching a ton of money for a state that really has no engine for really using that data to try and think about. So I think that's been a challenge for us in terms of trying to, and we've been trying to use our levers on both sides to say you should really think more about, especially when we're granting large sums of money for reinvesting into Medicaid, that you really need to think about your data solution from day one. So although we have national data problems, this is a way we've been trying to leverage some of that data out. So Oregon was one of those states, and they're giving us quarterly reports now. They're seeing, we kicked off a new demonstration last year, seeing early data, but drop in CHF rehospitalizations by 14%, drop in non-urgent ER visits by 10%, increase in primary care visits. So again, this isn't just tamping down care, it's a better pattern of care. So again, in some of these states, we're really trying to think about that. We're seeing some of that already.
Well, there's good work happening also in the state systems group at CMS for Medicaid, and if any of you guys are familiar with Medicaid, I mean, the systems that exist to track expenditures and clinical outcomes and cost and all kinds of stuff are let's use a polite word and say archaic. But as some new requirements come out, as we start thinking about new regs to govern how we spend money to support those systems, as the transformed TMSIS. I was trying not to use the acronym, but I couldn't remember what it stood for. But the point is, as these things come up, I think that we're going to start to get much better data out of Medicaid. And once we have that, I think the world changes. So you'll have the data points to use. You won't have data envy anymore. On that note, I want to turn it over to you guys. Maya tells me that you're a chatty crowd, so let's put her to the test. Who's got some questions for our esteemed panelists here? Start over here. Yeah. You got a mic. Yeah, we have roving microphones.
This is addressed to the government people. For the most part, do you guys make any of the raw data available? Usually when I go and search for data, I see things that have already been analyzed, so that you'll have actually put things into percentiles, you'll have distributed it, and so on. I'm more interested in that raw data that you use to get to the point that you actually published all this data and make it available.
Great question.
I can speak for ACL. Some of our data are available in the raw format. And so from the Aging Stats website, you can download the data in the tables, but from the Aged website, you can download the raw data. You can download the data tables from the Census Special Tabulation, from the National Survey of Older American Act participants, and that's an annual survey, nationally representative of the service of our service participants, and for the expenditure and other service data that we have. So some of our data is sort of already digested for you, but we do have some raw data on the websites that I pointed out to you that are available.
Just as a follow-up. Is there a rhyme or reason as to what you make available in terms of raw form versus what you don't?
That's a harder question.
I think I can speak to that. Privacy. So we provide grants to agencies to provide services. And if you're asking for raw data about who we serve, there's huge privacy concerns about which clients got HIV care. So we have to churn through that before we can make some of it public. And some of it we collect in a way that we won't be able to make it a raw file. So for our health centers, we collect it in a way that it's at a grant level. So we won't have data on a specific individual who got a specific instance of care. And I think this is probably something that Stephen can speak to with Medicaid, of how do you balance that privacy and openness.
So actually, I want to kind of throw it back to you for a second. Is there a particular data set that you have wanted to access in raw format that?
Well, very much like everybody else is asking, we would love to see claims data, good, hard, raw claims data, so that we can actually do all the processes. But it also extends to the things that we have in our planning stages for the future. So there are things whereby what we're finding is that a lot of times the analysis that you guys are doing and letting that data out, it is the algorithm that you are using, the way you're trying to decide things, are not quite what we're looking for. So we're actually looking to tweak the kind of things that you're doing to make it more useful to us. So an example that I usually give is that when you're looking at the KPIs for asthma treatment, right? Usually they're just based off of ICDs and CPTs and so on. But we also found that if you have drug data, you can actually distinguish between the people who are actually just non-compliant versus people who have intractable disease. They're trying to be compliant, but their asthma is just one of those cases. It's just very difficult to use. And that's not a fine point that your data gets to, or any of the KPIs that we've seen. So for something like that, we would love to see that raw data so that we could make that adjustment, and so we can now offer this and saying, our KPI is much better than what you currently have available to you.
So I want to jump in actually then on Paul's point. When it comes to claims data and personally identifiable information, there is a serious privacy concern that we have to take into account as the government. CMS has pretty rigorous processes, having said that, in place for people to request data for research purposes. So if you want to access claims data, you can go to the organization called RESDAC, it's RESDAC, and go through them to help configure essentially a request for a type of data that you might not have access to. The other thing that CMS has set up recently, and I don't think there's any Medicaid data in there yet, but there's this thing called the Virtual Data Resource Center, I can't remember, it's VRDC. And basically it's an enclave where you can essentially get a seat in that enclave with the appropriate research request to actually have access to data in a much easier and lower cost fashion than typically is offered. So there are ways to get at the raw data, it's just not something we can give away because of the privacy concerns.
We're not researchers, we're an entrepreneurial startup.
So, and which is another. Absolutely, and so that's another good point. One of the things that we are thinking about quite intensively, for years CMS has had a prohibition on letting commercial entities have access to claims data for very good reason. We don't want the drug companies marketing to people who potentially need the drugs, or people who make wheelchairs, calling up all the people who might need wheelchairs and saying, hey, we're going to sell you our stuff. But there are legitimate reasons, as you're pointing out. And so one of the things that we're having discussions about internally is whether or not we want to change that policy, and if so, how we can change that policy to be most effective. So stay tuned on this one. It's a really interesting point. And thank you for the question. Who's next? No? We've got one in the back.
Hi. My name is Greg Bloom. I'll come over here so I can see you all. I'm leading the Open Referral Initiative, which is a data standardization campaign. My sympathies to you all who are dealing with personally identifiable information. That sounds like quite a mess. We're dealing with something that should be much more straightforward and clean cut. The information about the services, where are they, how do you access them, what are their hours of operation, what's the process to actually get this service. We heard some great stories about what's being done with this information from Purple Binder and Healthify, but the actual act of getting this information is still very costly. Keeping it up to date is very costly. And there isn't going to be one solution to this problem, but certainly the federal government can play a role in publishing data about the services that it's funding. And we've looked at some of the data sets. They have mostly the information about the organization and the address. And maybe there are some who've actually found really useful information about the actual things happening at those organizations, but so far it's just, here is an organization that we funded, and and so I have a couple of questions. One is, what is the role for the federal government in supporting efforts to develop data standards that can make some of these challenging, complex problems a lot easier for the many different ways to address, for the many different people who are going to address it in different ways. And then the other is, where are the low-hanging fruits? What are the services that are out there that you know you want to get the public, like you want to push these out in ways that all the different services, whether they're 211, Purple Binder, Healthify, you want that information flowing through these systems as quickly and as broadly as possible?
Good questions. Who wants to take a stab?
I'll take number 2.
Go for it.
Okay, data standards, I'm going to kick that back to Brian. Low-hanging fruit. So, yeah, part of the data is the reason why we collected it in the first place. So, especially for Health and Human Services, we started collecting data in 1935. Yes, ladies and gentlemen, 1935. In the Social Security Act that established us in general, that's where we got our reporting standards. Government gave programs money, and we produced reports. And to this day, that's sort of what's still in place. So when programs get money, they report back. So that's why this conversation and ones like this are so important. We need to know what you want. What do you want to know? And so far, what, like with Code America, it seems to be like a mashup of the data. Our program data is all good and well, but if you mash it up with census data, then you can figure out this population is most likely served in this location. So we need to, and I think, Brian, I'll run this by you and Damon first. If you want specific data, contact us. And if we don't have it, we'll try and get it for you, on an individual basis for sure, because we want the data to be useful. We don't want it to sit and be dusty. We want it to be useful. So that was question 2, I hope.
Yeah, and I'll second that statement. I mean, one of the things that we, as sort of the owners of the Health Data Initiative, want to do is be that contact point and sort of disseminator to help make sure that the questions flow to the right places and things like that. So if there are specific questions, please come to us, and we'll try to find the right people within the department to answer those questions. Anybody want to take a stab at the first one around data standards and grantees and? I mean, I don't run any programs, so I could say some stuff, but you guys might not like it.
I want you to say some stuff, but I will say one thing on a second, which is, and I think this is what you're getting at, I think, but provider directories. I mean, in terms of accurate, real-time provider directories, I mean, I think there was just a front page story on a Times or Post about, some of the inaccurate provider directories for some of the plans on the marketplace. We need to do a better job there. So I don't think that's rocket science for any of us to be thinking about. So, but it's clearly we need to do better.
Yeah.
And I think my stab at that first question will be, this is not something we're not thinking about. And this isn't something we're not always having conversations about how do we, because we run into the same thing of we want to know this about where our services are provided. But I think from a grants perspective, it gets difficult because we give money, they report, like you said. And so how do we negotiate that balance of Well, if they tell us their hours in December, what's going to happen in January? What's going to happen in September? So I think that's something we're working on. And
Greg, do you have
hopefully
any
it'll be
ideas
lower.
on how to solve that? I suspect you might.
Well, so what you were saying, in other words, is that you can collect data at a point in time, right? And what I think we're saying is that if that data is made available in a common format, so that 211 providers, vendors of systems that actually make referrals can ingest it automatically, they will do the updating for you and publish it back so that you can actually get, in turn, improved open data that actually keeps track of, from the community, what are the services, how are they changing over time? I do think you all can play a role in getting us that baseline of here's this basic set of information.
Greg, knowing what you're working on, would you be willing to help folks in the government develop the standards that we could ask our grantees to support?
I mean, I came to this. And
I'm always trying to make these things about doing stuff. So,
thanks for that volley.
if you got, I've known Greg for a long time, back in the DC days, and he's been working on this particular problem now for what, 5 years, 6 years?
Yep.
I don't know many people more dedicated than Greg to trying to solve this one. So I think a really neat outcome of this conversation actually might be getting him and his work plugged in with some of the stuff that we're doing to try to figure out if there is a way that we could help define a standard that we could put to our grantees to say, hey, maybe we can provide technical resources or assistance or what have you to publish data in this way so that folks like Greg and others that are trying to do interesting things like you guys could actually take advantage of that open data, which you can imagine would significantly improve our reach in the way that we help the communities that we're really trying to serve. So I'll just leave that out there, but the work that he's doing is pretty interesting. So, who's next? Yes. We've got one in the back. Let's do the back and then you. Okay.
Hello, my name is Letitia Ingram, and I'm currently on a detail from the Bureau of Primary Health Care to ACF working on human trafficking. And one of the things that we're looking at is the possibility of how to develop a screening tool for our demonstration grantees that will also fit in with Office of Refugee Resettlement, a uniform way to identify the services and the needs of human trafficking victims. Our real goal is to identify the number of victims served and as well as the number and the types of services that they have. And I'm mainly interested in Purple Binder and Healthify. It seems like you all already have screening tools that are modifiable and maybe used for nonprofit organizations. And I wanted to know if you've had any demonstrations or any best practices around the human trafficking organizations as we kind of look forward to expanding in the domestic area.
Yeah, great question. I can say that we've done a lot of work with screening assessments and how to develop screening assessments for a variety of populations, understanding cultural competency issues, understanding multiple languages, literacy issues that all have to be looked at very carefully. And I can talk about some of our learnings in that. Specifically in human trafficking, we have not done any work there. Most of our screening assessments have been primarily done in adolescent Medicaid population and also caregivers for caregivers who are actually supporting care recipients who have chronic illnesses. But yeah, I love to chat. Our screening tool can probably help with that. And some interesting things we found, I think it might be relevant for human trafficking, is sometimes our screening tool is deployed with a staff member that asks the questions with someone, which works well. And we ask one question per page, and we allow people to understand hints and things like that. But we also have done deployments in primarily outpatient primary care settings where people complete the screening on their own. And we're hopefully going to be testing this in libraries and community centers as well. They take a screening on their own and follow up and get potential interventions and referrals and help. And what we found is that tricky subjects to talk about in person, whether it be substance abuse or mental health services, people are more likely to reveal information to our web-based tool on their own than they would to any healthcare provider or staff who's administering the tool with them. So that degree of anonymity with the web-based tool is actually pretty powerful. That initially seemed pretty counterintuitive to us. So we had some experience there, and I'd love to chat more.
Yeah, and currently, Purple Binder does not have a built-in assessment tool. We found that a lot of the people that are using it, a lot of the organizations and hospital systems actually have their own assessment tools. So that's not something that we currently have. But definitely, in our portfolio of resources, there's definitely tons of nonprofit organizations that we partner with that do provide services to support trafficked youth and adults as well as refugee.
Great, thank you. I think we had a question here.
Sure. Bill Fisher. Enjoyed hearing the example earlier from one of the presenters around text for baby, referenced as a kind of a best practice. I was curious to hear from the group if you see other good potential use cases. Wow. Should I start singing now? Any other? Oh, okay. Any other relevant use cases for using mobile and SMS text specifically to engage underserved communities and improving health outcomes? I've got to believe that there's other good use cases out there, and just curious to hear your thoughts on that.
Yeah, I can talk at length about this. So there are a lot of people who are testing texting solutions to help care managers and help people manage chronic illness. I'll give a shout out to one of our good friends at Sense Health that are actually developing behavioral health scripts via text directly to Medicaid recipients, and recently published a paper with Montefiore about the efficacy of this, and it works really well. We do texting as well. Our texts are primarily looking at referrals. So if we refer someone to a community center, we ask them, did you go? Did you find it helpful? Do you need directions to another referral, which we think is useful. But there's a lot of evidence out there that this works really, really well and is a great help in reducing the behavioral hurdle to access services and actually manage care. Some research is coming out. So Hennepin Health System has done some great research on SMS usage in their ED department. They looked at people who are at risk for homelessness or identified as homeless. What is their percentage of having an SMS-enabled phone? It's over 80%. But the caveat being is that this is not in every community. We did ride-along visits in Florida. We worked with about 35 community health workers in Florida. And then in the rural parts of Florida, SMS usage is not going to be a modality that can be used effectively. But you look at urban communities in New York and in Baltimore, where we're also operating, it is 90, 95%. And if you aren't texting for engagement and outreach, you need to. I think it's very important.
Some areas that we're interested in that type of technology, and we've seen some of our grantees use it, is with medication management. And so with individuals who may have to take multiple medications on very intricate schedules, having texting and other types of reminders like that can be very helpful. And so we're very interested in that kind of thing. And also with some of our preventative health and wellness programs. Many of them are built to empower people to better manage their chronic conditions, reduce their risk of falls and various other things, to exercise and things like that. And while many of them that we promote are evidence-based, session-based, people meet, or they may be web-based sessions, texting is a way that some of our grantees have kept the community going, if you will, because a lot of these evidence-based programs, people build sort of a group within the 6 sessions or 10 sessions that they go to. They build support systems and community within those systems. And so being able to text afterwards, a month later, 6 months later, see how people are doing, remind them of their goals and things like that, because we are trying to change their behaviors and have them stick with those changes that they have agreed to and that they think that they can manage. Texting, I think, has a lot of potential in those areas as well.
Great examples. Anybody else want to add to those examples?
I mean, the only thing I'd add, and I did mention the text for baby, it's a little unusual in that it's sort of the primary modality for text for baby. I think we see texting as a key piece of a lot of different types of models rather than the thing on its own, right? And so I'm thinking about diabetes prevention programs. I'm thinking about Project ECHO and some of the interactions with providers and not just with the beneficiaries. I mean, there's a ton of engagement in terms of this being a tool for engaging. And I mentioned Project ECHO because it's not just between beneficiaries and providers. It's sometimes between providers and providers.
And I want to add 2 more things. Something we have encountered is that the legality of texting from the healthcare's perspective, the protocols and standards are not in place yet, and there's always a back and forth with legal departments. Is this valid? Can we do this? Can we not do this? Clarity on that would be awesome. And second, for developers in the audience, another company I want to give a shout out to that I think is doing great work in texting for underserved populations is Care Message, based out in California. And I know that they are actually working on an API for their text messaging solutions as well. So there's a lot of great texting work going on.
Great. So I think we have time for one more question, which I believe is you because you have the microphone.
perks of getting the microphone. Well, I just want to first thank the esteemed panel and the organizers. This has been very insightful. I'm from Utah, from University of Utah and Intermountain Healthcare, and our work is around improving quality of care for pediatric populations, specifically the care coordination for children with special needs and such. So I have two questions. My first question is around what are the upcoming priorities from the CMS's perspective that can translate to opportunities for us for the pediatric population and such. I know the Medicaid Innovation Accelerator program was mentioned, but I would like to know more about the priorities from the CMS perspective.
Sure. So what she's referring to is the Secretary announced last July the kickoff of the Medicaid Innovation Accelerator program. And this is an effort to provide technical assistance and support for our state partners, sort of recognizing that we're already doing payment and delivery reform. How do we actually figure out how to do that well? So I think a couple of people mentioned up here the idea of best practices, information about how we do this better. That's what this is really targeted around, about how do we figure out how to carve that pathway forward to find our way through that maze after we've moved the cheese, if you will. So I think specifically we've kicked it off in terms of thinking about substance use disorder, superutilizers, long-term services and supports, and integration of mental health and behavioral health. So these are 4 domains, care areas. We've already kicked off our substance use disorder. We have 8 states working with us intensively, another 18 that are working with us on a more low-key basis. We'll probably kick off our superutilizers soon. Certainly, kids are a key population within all of these issues and areas, and I think we're trying to pay particular attention to how we think about the opportunities that we have there. Because I think part of the idea for the accelerator program was we have some great pathways around the Medicare population, and there are certain areas like kids, like behavioral health, like maternity care, where we know we can do better, and we see pockets where we've seen pockets of hope in terms of trying to do better, and how do we systemize and translate those lessons and disseminate them more broadly. So we're just getting going now with the Innovation Accelerator program, but I hope we'll have more data to report and more information in the very near future.
So I was wrong. We could actually do one more. Oh, wait, we have one.
Yeah.
Okay.
So anything to add from the ACF side for the pediatric population at all?
Well, it's neat. We are actually starting to use our data and mash it up, as Brian likes to say, the data mashup with the Census Bureau. And so we're doing a lot of studies, a lot of research. The acronym has left my head.
For which?
Anyway, our research, we have a huge research operation, and they do specific tasks. Like they'll
ASPE or?
Thank you.
Okay.
For some odd reason, when a government person forgets their acronym, it's just a bad thing.
Assistant Secretary for Planning and Evaluation.
Thank you. Thank you. Would you want to talk to more about the things that ASPE is doing recently?
Well, I mean, they're tasked. That organization is tasked with looking across the department at various initiatives and measuring the effectiveness of it, putting out research reports. A lot of just as an example, a lot of the data that's coming out of the health insurance marketplace is generated by and sort of summarized by and released by ASPE. So they do all kinds of stuff. I mean, it's across the board. I'd recommend checking out their website to see the kinds of work that they're doing and the kinds of reports that they're focusing on at this point in time.
What does it stand for again?
Assistant Secretary for Planning and Evaluation. It's kind of a terrible title for what they do, but that's their job. Yeah, we can do one more.
Hi guys, my name is Alex. I'm actually from UC Berkeley. I'm kind of involved with a telehealth project, and kind of going off the texting question, I kind of wanted to understand what the government's perspective was, or any thoughts you guys have about the new field that is telehealth and communications between patients and providers.
Good question. Who wants to take a stab at that?
I'll start, which is that I think there's a lot of activity going on in telehealth from the Medicaid side, and I think a lot of our states are really trying to think forward-leaning about this. Utah, speaking of Utah, Intermountain came in and met with me last year, and they said, we really want to do telehealth. And I said, you can do telehealth, and here's how, and talk to your state. And they came back this year and said, we're doing telehealth. So it's, the point here is that I think we have lots of flexibilities, and I think, with the example of Utah, it sometimes can be turned around quickly in terms of getting these programs launched. The challenge for us and our state partners together is thinking about the standards. What is a good telehealth program? What does that look like? I think Utah was a little unusual because basically Utah and Intermountain have such a great relationship. They're basically like, Intermountain, you're great, sure, let's go for it, right? A lot of states are, have a wide range of providers, and they're saying, I don't want to go here unless I know what I'm paying for, and I don't really trust my providers just to deliver good services here. There are not great standards out there. There aren't great sort of definitions for what a good telehealth service looks like. We have flexibility, but we haven't, we're still learning. And so I think my point here is this is a great opportunity to, again, define best practices and continue to inform us in terms of what we should be paying for. And we look forward to conversations with people like yourselves in terms of what we really should move forward. The one other thing I'll mention is that, and I mentioned this before, but I realized I didn't even explain what it was, Project Echo, which is a model that is not actually about telehealth, but it is more about the limited access to specialists under Medicaid. And so Project Echo will connect a primary care doc with a specialist, start in the area of hepatitis, and the primary care doc can bring 4, 5, 6 cases to the specialist and say, what should I do with these, and have a conference about them, and boom, 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 that way, particularly for rural patients, they don't have to travel to see the subspecialist. Great data in terms of the impact here, and I think we just approved Colorado to move forward with starting a Project Echo. New Mexico is also moving. So again, I think we're rapidly moving forward, but I think we need to learn more about and get more feedback in terms of how this is going.
And I'd like to expand that a little bit and not just think about clinical health and telehealth that way, but also social services and some of the preventative health care and things like that. I mean, a number of the individuals that we work with are in very rural and remote areas. When we think about our tribal programs, when we think about some of the larger states with large rural areas, and the services that we provide, some of them have to be provided face-to-face. A meal has to be given to a person. But a number of the other aspects that we provide could be done, the checking in on people, the medication management, some of those types of things could be done through texting, telehealth types of things like that. So I'd like to expand telehealth from clinical to also think about where it fits in with these social services that some of us provide more so than we provide clinical services.
Paul, I think I'd like to hear what you have to say.
I think they've hit it on the nail on the head, but I just would want to name drop within HRSA, HHS's Office of Rural Health Policy is very actively engaged in telehealth and programs for figuring out how to support the networks necessary to get telehealth to work in those rural areas where there's the most need. So.
Absolutely. And the FCC is thinking about it. There's all kinds of stuff happening in Congress right now around this. Just my personal perspective is that this is a very interesting year for telehealth. And I think by the end of 2015, we'll start to see some real progress on this. It's just my opinion, but you kind of see all the signs pointing in a certain direction and kind of think that you're on the right track. So we'll see where it goes. On that note, please, let's give a big hand to the panelists. Thank you guys so much. And to the folks who set this up, thank you for putting this all together. This was wonderful. Thank you guys for coming. Have a great night. It was great to see you.